Hello, my name is Amy Besnell. I am one of the hospitalists in the Oncology Hospital Medicine group at Dana-Farber and Brigham and Women's, and our topic tonight is the Oncology Board Review. This is an entirely question and answer format, and I'm very grateful to be here tonight and look forward to discussing these things with you and any questions that you may have. I have one disclosure, but it is not relevant to tonight's presentation. Question 1. A 63-year-old woman previously completed 5 years of tamoxifen after undergoing lumpectomy and radiation therapy for a 1.5 centimeter ER-positive, node-negative breast cancer. She presents to your office with severe localized low back pain. Physical examination is normal, including the neurologic exam. The alkaline phosphatase is 330, which is elevated, and the CA2729 is 156, also elevated. A bone scan is positive in several areas of the thoracic and lumbar spine, as well as in several ribs. The first course of action at this point should be A, combination chemotherapy, B, hormonal therapy plus or minus a CDK inhibitor, C, MRI of the spine, D, radiation therapy to areas of localized disease, or E, systemic staging scans and bone biopsy. So the answer is, in terms of the most urgent thing to do, to get an MRI scan of the spine. You must rule out or rule in spinal cord compression. Outcome is best by far if the problem is identified and treated prior to the onset of neurologic findings. If there is severe focal pain, this must be evaluated with an MRI. In terms of the other question possibilities, for A, combination chemotherapy, this is almost never, or essentially never recommended with metastatic breast cancer. Hormonal therapy plus or minus CDK inhibition is the standard frontline therapy for metastatic hormone receptor positive breast cancer. However, we need to deal with cord compression and confirm the diagnosis first. Radiation therapy or surgery would be the appropriate interventions for cord compression, but the first thing to do is to see if that is present. And finally, systemic staging scans and a biopsy to confirm the diagnosis and any molecular studies is going to be a key part of the care, but it is not the most urgent issue. Next question. A 68-year-old male presents with back pain, anemia, and fevers. He has no lymphadenopathy or splenomegaly. Laboratory studies are notable for a hematocrit of 34%, a total protein of 9.8 grams per deciliter, a creatinine of 3.2, and a calcium of 12.3. Plain x-rays of the spine show generalized osteoporosis without focal defects. Which of the following is true? A, fever is a worrisome sign and infection is a life-threatening risk in this disease. B, renal failure is likely a consequence of dehydration. C, the patient should undergo CT scans with contrast to evaluate the source of fever. D, the lack of lytic lesions argues against an underlying diagnosis of myeloma. Or E, IgA and IgG paraproteins have similar serum viscosities. And the answer is A, fever is a worrisome sign and infection is a life-threatening risk for myeloma patients. Fever is not a common disease presenting feature, but infection is. And given the immunosuppression of patients with myeloma, it is critical to recognize infections and treat immediately. In terms of the other possible answers, renal failure is indeed common and it can be for multiple mechanisms, often all going on at once. You can see some of the mechanisms there, and additionally dehydration in the setting of hypercalcemia is often a major contributor. In terms of IV dye, patients even with normal creatinine and myeloma are at higher risk of injury, so this should be used very judiciously even with normal renal function, and IV contrast for CT should be avoided in the setting of acute or abnormal kidney function. In terms of bone abnormalities, although the lytic lesions are classic for multiple myeloma, by far the most common finding on plain films is just osteoporosis, and for staging, other modalities are much more sensitive for picking up bone involvement. In terms of serum viscosity, IgA and IgG are different. IgG is a smaller molecule and IgA tends to have a higher serum viscosity, although it is somewhat unpredictable. IgM by far has the highest serum viscosity, but IgM multiple myeloma is rare. Question 3, a 46-year-old woman presents to your office for routine health care. She is concerned about the possibility of developing breast cancer and asks you about her risk factors. Which statement is correct? A previous history of LCIS or lobular carcinoma in situ does not substantially increase her risk of developing breast cancer. B, Presence of a BRCA1 germline mutation will substantially increase her risk of developing breast cancer. C, a maternal aunt with postmenopausal breast cancer will substantially increase her risk of developing breast cancer. D, the majority of women with breast cancer have identifiable risk factors for the development of breast cancer. Or E, duration and degree of estrogen, both endogenous and exogenous exposure, is not associated with increased risk of developing breast cancer. And the answer is B, a BRCA1 or 2 mutation will substantially increase the risk of breast cancer. On the order of 50 to 80% of women with these mutations eventually develop breast cancer. In terms of the other answer possibilities, LCIS is actually associated with an increased risk of developing a future invasive breast cancer on the order of about 1% per year. In terms of family history, having a paternal aunt with breast cancer will slightly increase her risk, but the risk is much more notable with first-degree relatives or younger age. And the majority of women have no identifiable risk factor for developing breast cancer other than being a woman. And association and exposure to estrogens is definitely associated with an increased risk of developing subsequent breast cancer. A 67-year-old male smoker presents with headaches, forgetfulness, and poor coordination. Several times over the past few weeks, he has had periods of confusion and urinary incontinence. A head CT scan reveals multiple round enhancing lesions. A chest X-ray shows a 2-centimeter lesion in the right mid-lung field. The most likely diagnosis is A, prostate cancer, metastatic to lung and brain, B, pneumonia with brain abscesses, C, colon cancer with lung and brain metastases, D, non-small cell cancer of the lung with brain metastases, or E, gastric cancer with lung and brain metastases. And the key to this question, of course, is what is most likely. Any of these are theoretically possible, but by far the most likely explanation is D, brain metastases from a primary lung cancer. Brain lesions are one of the most common sites of metastases with lung cancer, both non-small cell and small cell. This patient is a smoker and certainly could be at risk for either of these conditions, but given that the vast majority of lung cancers are non-small cell in the order of 80% or more, the most likely diagnosis is non-small cell lung cancer with metastatic lesions to brain. In terms of colon or gastric cancer, it is just much less likely to have brain metastases and also less common to have early lung metastases. Pneumonia with brain abscess is of course possible, but clinically doesn't fit, and this is an oncology review session. A 26-year-old woman with Hodgkin lymphoma and bulky mediastinal disease is treated with ABVD and radiation to the mediastinum. Which of the following is most true? A, she is more likely to die of other causes than her Hodgkin lymphoma. B, given she is over 20, she is not at increased risk of breast cancer. C, she should receive bleomycin with every cycle of chemotherapy. D, she is likely to have difficulty with fertility in the future. Or E, she is not at increased risk for heart disease. Now, many of you may know that the precise optimal treatment for early stage Hodgkin lymphoma in young patients is getting quite controversial now that we have increasing options. However, in this patient who's received ABVD and radiation with early stage disease, we do know some of the subsequent risks. So the answer to this question is A. Her lymphoma itself is highly curable, but there's an increased risk of mortality from other diseases related to treatment, including heart disease and secondary cancers related to her chemotherapy and radiation. In terms of why the other answers are not correct, for B, breast cancer is actually significantly increased in women who receive radiation to the chest for Hodgkin lymphoma under 30. And guidelines currently suggest more aggressive screening for women who do undergo radiation under the age of 30, with the recommendation in general to start within 8 to 10 years of completion of radiation and to include MRI along with mammography and screening. In terms of the other answers, for C, bleomycin is now frequently dropped if there is a negative PET scan after 2 cycles of therapy, which decreases the risk of developing long-term and even potentially fatal pulmonary fibrosis from this drug. Women who receive ABVD and chest radiation actually have no significant decrease in fertility or risk of birth defects. And E, she is definitely at increased risk for heart disease, both through the risk of direct coronary disease from radiation and a cardiomyopathy from the doxorubicin. A 46-year-old Asian woman who has never smoked is diagnosed with stage 4 non-small cell lung cancer with metastases to the liver and bone. Which of the following is correct? A, she is potentially curable with intensive modern chemotherapy. B, the likelihood of responding to an EGFR kinase inhibitor is related to the presence of a mutation in the kinase region. C, the likelihood of having a mutation of the kinase region of EGFR is random and not related to gender or ethnic background. D, cytotoxic chemotherapy is the only potential beneficial treatment. E, resistance to kinase inhibitors is rare. And the answer is B, the likelihood of responding to an EGFR kinase inhibitor is most definitely is most definitely related to the presence of having a targetable mutation in the kinase region. And in fact, this would be the frontline choice of therapy for a patient with one of these mutations. And we test all patients up front for EGFR mutations with stage 4 disease. In terms of the other answers and why they're not correct, A, she definitely is incurable. Survival is increasing dramatically with newer treatments, including targeted therapies with EGFR inhibitors and immune therapy, but stage 4 lung cancer remains incurable. And in terms of C, the likelihood of having an EGFR mutation is most definitely increased in women, non-smokers, and people of Asian descent. D, she has an excellent chance of responding to an EGFR inhibitor if she has a sensitizing mutation. And E, development of resistance to EGFR inhibitors is universal over time. Question 7. A 22-year-old man presents with a left supraclavicular mass and an otherwise normal physical examination. Chest X-ray shows a widened mediastinum. Aspiration and cytology of the supraclavicular mass demonstrates an undifferentiated carcinoma. The next clinical action should be A, institution of multi-agent chemotherapy, B, MRI scan of the chest, C, mediastinoscopy and biopsy of the paratracheal nodes, D, testicular ultrasound, or E, institution of radiation therapy to the mediastinum and supraclavicular areas. And the answer here is D, a testicular ultrasound. And a young man with adenopathy and a poorly differentiated neoplasm, testicular cancer is the most likely and the most curable diagnosis. So there can often be an occult testicular primary with this pattern of spread to the mediastinum and supraclavicular nodes, and is one of the most common malignancies in this age group. If a testicular lesion is found, he should undergo orchiectomy for diagnosis as well as treatment. In terms of the other potential answers, multi-agent chemotherapy will almost certainly be indicated, but we need to come up with the precise diagnosis first, and a fine needle aspiration is often insufficient for clear diagnosis for germ cell tumors and certainly for lymphomas. An MRI of the chest will not add anything additionally helpful. Mediastinoscopy and biopsy of the chest nodes may be indicated if there's no testicular lesion, and additional pathology is needed, although a node, a supraclavicular node, would certainly be easier to resect. And in terms of radiation, this would be purely palliative, and systemic treatment and firm diagnosis would be the first order of business. In which of the following patients would yearly screening with low-dose CT for lung cancer not be considered? And the caveat of this question is there are many different guidelines, but this takes kind of the most general amongst all the various guidelines which have been issued. A 47-year-old woman with a 2-pack per day active tobacco use and history of lung cancer in both of her parents. B, a 57-year-old woman with a history of smoking 1 pack per day from ages 15 to 50. C, a 70-year-old gentleman with asbestos exposure, 50-pack year history of tobacco use who quit smoking at age 58. D, a 75-year-old woman with an active 1/2 pack per day of cigarette use since age 30. Or E, a 60-year-old man with a 50-pack year history who stopped smoking after an MI at age 50. And the answer is A, woman under 50 with active tobacco use. As I mentioned previously, there are several different criteria based on different organizations issuing screening guidelines, but some comprehensive principles are that the age is in the 55 to 79 range, with at least a 30-pack year history of tobacco use and active use within the past 15 years. So the first woman at age 47 is younger than any of the current guidelines, although certainly we would have a low suspicion to test her with any symptoms, and the remaining of patients would be considered reasonable candidates for CT lung cancer screening. Question 9, a 28-year-old man is admitted to the hospital with a new diagnosis of acute lymphoblastic leukemia. Which of the following clinical characteristics would convey the worst prognosis? A blood blast count of greater than 200,000. B, T cell phenotype as opposed to B cell phenotype. C, a mediastinal mass. D, presence of the Philadelphia chromosome in the leukemia cells. Or E, thrombocytopenia. And the answer is D, the presence of the Philadelphia chromosome. This is definitely a poor prognostic finding in adult patients, although is less concerning in the young patients. This requires often more intensive therapy and in general a consolidative allogeneic stem cell transplant for cure. One silver lining, however, is that in older patients for whom curative therapy is not an option, having the Philadelphia chromosome does present a targetable palliative option. In terms of the other answers and why they're incorrect, the presence of thrombocytopenia or high blast count and presentation does not affect prognosis in ALL. And in general, a T cell phenotype and a mediastinal mass, which are often related, confers a better prognosis and does not require upfront consolidative stem cell transplant in general. A 77-year-old woman with stage 4 non-small cell lung cancer has been doing well for several months on maintenance pembrolizumab and pemetrexed. That's a combination of immune therapy and chemotherapy. She then presents to the ER with rapidly progressive dyspnea over the past week, accompanied by a dry cough. She has not had fevers or sick contacts. In the ER, oxygen saturation in the room air is 82%, respiratory rate is 22. A chest x-ray is unremarkable. EKG shows tachycardia. She undergoes a PE protocol CT, which does not show clot. It does confirm a stable right hilar mass with her known disease and new diffuse granulous opacities in areas of mildly increased interstitial markings. A BNP is normal at 200. A recent echocardiogram showed relatively normal pulmonary artery systolic pressures and a normal EF. Along with admission to the hospital, which of the following interventions is indicated? And I should say is most indicated. So the possibilities are A, pip/tazo plus vancomycin for healthcare-associated pneumonia. B, enoxaparin for suspected small vessel thromboembolic disease. C, steroids at a minimum dose of 1 milligram per kilogram of prednisone or IV equivalent. D, etanercept, or E, furosemide. And the answer is C. This is very concerning for immune checkpoint inhibitor-induced pneumonitis. We often see this most commonly in the first 2 to 3 months of therapy, but it can occur even years out. And early initiation of steroids in this condition is critical to optimizing outcomes. In this patient, without significant clinical evidence of infection or CHF, with these new symptoms and the radiographic appearance, it is critical to start steroids. If hospitalization is required, we often use IV steroids up to a dose of 2 milligrams per kilogram of solumedrol, but certainly a minimum of 1 milligram per kilogram of prednisone is recommended. In terms of the other answers, it is true that we often will use a more shotgun approach. Atypical pneumonia could look like this, and antibiotics are often prescribed, but steroids are key. In terms of Lovenox, we certainly don't want this patient to get a clot, but there's no clinical evidence of chronic thromboembolic disease on the available data. D, etanercept can be a very useful salvage agent if steroids do not work with immune checkpoint inhibitor pneumonitis, but it is not first-line therapy. And diuresis certainly is considered, but again, is not the most likely diagnosis here. And so the key point of this question is to start steroids if you suspect checkpoint inhibitor pneumonitis. Question 11, a 46-year-old woman with epithelial ovarian cancer, that's standard ovarian cancer, at surgical debulking is found to have bilateral ovarian masses with multiple peritoneal and amental nodules, as well as ascites. All the tumor that can be removed is removed, but tumor masses of 2 to 3 centimeters remain, which implies non-optimal debulking, which would be complete removal of all visible tumor or no tumor masses greater than 1 centimeter. There is no evidence of disease outside of the peritoneal cavity. Postoperatively, the patient is treated with paclitaxel and carboplatin for 6 cycles. Which of the following is true? A, she has a very low chance of response to chemotherapy and a very low chance of cure. B, she has a high chance of complete clinical response, but a low chance for cure. C, she has a high chance of response and a high chance for cure. D, she will need radiation therapy to the entire abdomen. Or E, she will need localized radiation therapy to the pelvis. And the answer is B. She has a high chance of complete clinical response, even without optimal debulking, but a low chance for cure, even with optimal debulking. So these women tend to respond very well to treatment, but most people recur, which explains why answers A and C are incorrect. In terms of radiation, this is almost never used. It is very toxic. It is not curative, and we have very good systemic options, especially for frontline treatment. A 72-year-old man presents with hematuria. Cystoscopy reveals multiple bladder nodules, which are biopsied and reveal transitional cell carcinoma or urothelial carcinoma. Those are interchangeable terms. The likelihood of developing metastatic bladder cancer is most closely related to A, the size of the tumors in the bladder, B, the number of tumors in the bladder, C, a history of smoking, D, a family history of bladder cancer, or E, bladder wall muscle invasion by tumor. And the answer is E, bladder wall muscle invasion by the tumor. This is the single most predictive feature of early stage bladder cancer. And indeed, if there is no muscle present on the biopsy specimen, the patient must be rebiopsied to see if there is invasion into the muscle. This is critically important, but still we will see patients who had non-muscle biopsies and come back later with invasive disease or metastatic disease. In terms of the other answers and why they're not wrong, tumors can be quite large and there can be quite a large number of them, but without muscle invasion, the risk is much lower of developing metastases. In terms of smoking and family history, these are both risk factors for developing bladder cancer, but are not associated with increasing the risk of metastases once the bladder cancer is present. A 32-year-old man presents with fevers, petechiae, and fatigue, and is found to have acute myelogenous leukemia. Allogeneic bone marrow transplantation, presuming a suitable donor can be found, will most likely be recommended if A, his initial blast count is greater than 100,000, B, he is septic at presentation, C, he has acute promyelocytic leukemia and presents in DIC, D, his blasts have a 7q minus deletion, or E, his blasts have an 821 chromosomal translocation. And the answer to this question is D, leukemic blasts with a deletion 7q. So the principle of this question is that poor prognostic molecular and chromosomal features is by far the main reason that we proceed to transplant in AML. In terms of the other questions, for AML, blast count does not affect prognosis. Sepsis does not affect prognosis, although it certainly affects the chance of survival at presentation. In terms of C, acute promyelocytic leukemia with DIC is actually one of the most curable types of acute leukemia if you can get them through the initial DIC and induction. And then E is not correct because 821 translocation is actually one of the good prognostic features and can often be cured with chemotherapy alone. You are evaluating a 52-year-old man with newly diagnosed non-small cell carcinoma of the right lung. In which of the following scenarios is the patient potentially resectable with a goal of cure? A, contralateral or N3 mediastinal adenopathy. B, an enlarged and suspicious left adrenal lesion. C, ipsilateral pleural effusion. D, ipsilateral mediastinal nodes, which would be N2 nodes, or E, ipsilateral supraclavicular adenopathy. And the answer is D. Patients with up to stage 3A or an ipsilateral mediastinal node involvement are potentially curable with aggressive therapy. The ideal management of patients with stage 3A lung cancer is somewhat controversial, but often includes resection and chemotherapy and radiation. In terms of all the other scenarios, having N3 nodes, either ipsilateral or contralateral supraclavicular or contralateral mediastinal nodes, would make a stage 3B disease in which resection has not been shown to increase chance of cure. And having even oligometastatic disease or pleural effusion would make this an incurable situation. And stage 4 and resection would not be recommended. Which of the following is true regarding tamoxifen and raloxifene? A, raloxifene is a bone strengthening agent, but tamoxifen is not. B, both drugs increase the risk of endometrial cancer. C, both drugs decrease the risk of developing a future breast cancer. D, tamoxifen increases the risk of hot flashes, but raloxifene does not. Or E, tamoxifen increases the risk of venous thromboembolism, but raloxifene does not. And the answer is C, that both are good agents for decreasing the future risk of developing breast cancer. A, both of these drugs can increase bone density, and in fact, that's probably the main reason that raloxifene is used these days. In terms of B, this is an important point. Tamoxifen increases the risk of endometrial cancer, but raloxifene does not appear to. This has to do with how the effect of estrogen is on the endometrial tissue between the drugs, where tamoxifen does give an increased estrogen effect, but raloxifene does not on the endometrium. And then both drugs can increase the risk of hot flashes and venous thromboembolism. A 42-year-old premenopausal woman presents with a 3-centimeter, poorly differentiated, hormone receptor negative, HER2 positive invasive ductal carcinoma with 5 involved axillary lymph nodes. Which of the following is true? A, the presence of HER2 on breast cancer cells does not affect prognosis. B, adjuvant chemotherapy is not effective in reducing the subsequent development of metastatic breast cancer. C, HER2-directed therapy, including trastuzumab and pertuzumab, when added to chemotherapy, substantially reduces the risk of developing metastatic disease in the future. D, letrozole, an aromatase inhibitor, would further improve the cure rate for this patient. Or E, the addition of trastuzumab to chemotherapy is safe without any short and long-term complication risk. And the answer is C, using HER2-directed therapy with chemotherapy significantly reduces the risk of developing metastatic disease in the future. In terms of why the other answers are incorrect, tumors which overexpress HER2 are much more likely to recur metastatically than are hormone receptor positive only, unless HER2 therapy is given as well. So that is absolutely mandatory with HER2 positive tumors. In terms of B, adjuvant chemotherapy significantly reduces the risk of developing metastatic disease in the future with node-positive disease. D, letrozole, an aromatase inhibitor, is not effective in non-hormone receptor positive breast cancers, as is this case, nor is it effective in premenopausal women unless the ovarian function is suppressed. And trastuzumab and pertuzumab both can have cardiotoxicity. And indeed, every 3-month echocardiograms are recommended while on these drugs to assess for asymptomatic drop in EF. A 56-year-old man with a history of primary melanoma on the right forearm 3 years ago presents with hepatomegaly and is found to have metastatic melanoma in the liver. Molecular studies show BRAF wild type. PET CT and brain MRI show no other sites of disease. Which of the following is the best treatment option? A, dacarbazine and tamoxifen. B, no therapy is recommended at this point given low response rates and the patient should be placed in hospice. C, checkpoint inhibitor therapy with either nivolumab plus ipilimumab or single agent pembrolizumab or nivolumab. D, prophylactic brain irradiation. Or E, dabrafenib and trametinib. The answer is C. Immune checkpoint inhibitor therapy is highly active in metastatic melanoma. The ideal regimen is not known. A combination of ipilimumab and nivolumab has very high response rates, but combined checkpoint inhibition also has increased risk of autoimmune toxicity, so not all patients can tolerate this. Additionally, single agent PD-1 therapy, and both nivolumab and pembrolizumab are approved for this, are acceptable options, so he should certainly be offered checkpoint inhibition therapy. In terms of why the other answers are incorrect, chemotherapy with dacarbazine was the old standard of care, but is not overly effective, and tamoxifen did not add improved response rates at all. In terms of hospice, some patients choose this, but all patients should at least be considered for checkpoint inhibitor therapy with metastatic melanoma. D, brain metastases is a common occurrence with metastatic melanoma, but preventive radiation does not help. We really only consider this in small cell lung cancer. And then E, BRAF-directed therapy can be very effective, at least in terms of immediate responses, although resistance can develop later. But this patient is BRAF wild type, so would not respond to BRAF therapy. A 64-year-old woman has a routine CBC, which shows a white blood cell count of 14,500 with 75% mature appearing lymphocytes. On smear, hematocrit is 41% and platelets are 180,000. She has no adenopathy or splenomegaly on exam and feels well. Which of the following is true? A, the diagnosis of CLL can only be made on a bone marrow aspirate and biopsy. B, she is at increased risk for infection. C, she is in need of urgent chemotherapy. D, she is likely to die of CLL before her 70th birthday. Or E, splenomegaly is rare in patients such as this one. The answer is B. She is at increased risk for infection. This is due to the decreased antibody production and dysfunctional immune system in patients with CLL, even in stage 0 CLL with an asymptomatic lymphocytosis and otherwise normal counts. Infection is the leading cause of death in patients with CLL, for whom the death is attributed to the CLL itself. Most patients die of unrelated causes, of course. In terms of the other potential answers, CLL can absolutely be diagnosed with peripheral blood flow cytometry. And indeed, doing a bone marrow biopsy in CLL is relatively rare. We tend to do it when we're trying to see if somebody has immune-mediated cytopenias or progressive infiltration of the marrow with CLL. Otherwise, peripheral blood, because by definition the disease is circulating, is perfectly adequate for any sort of molecular genetic testing or diagnostics that we need. As I hinted at previously, many patients with CLL live without therapy for many years and often do not require treatment. The indications for treatment would be non-immune severe anemia or thrombocytopenia, bulky adenopathy, or systemic and general B symptoms. And statistically, she is likely to be alive many years hence, despite having CLL, and splenomegaly is common, but is not an indication for treatment by itself. And we'll end up with a couple of bulk questions here looking at mechanisms of action and toxicity. So for this question, we're looking at mechanism of action and the appropriate antineoplastic agent. So which of these drugs leads to stabilization of the microtubule assembly, inhibition of HER2, inhibition of VEGF, alkylation of DNA, and decreased T cell inactivation by tumor? And the answers to these are number 19, the stabilization of microtubule assembly is paclitaxel and other taxanes. These work by stopping ongoing mitosis and stabilizing the mitotic microtubule assembly. 20, HER2 inhibitor is trastuzumab. 21, VEGF inhibitor is bevacizumab. This works by decreasing new blood vessel formation signaling by tumors. Alkylation of DNA, number 22, is cyclophosphamide. This is one of the original alkylators and one of the original classes of chemotherapy. These are nitrogen mustard derivatives. And 23, increasing the T cell response via blocking tumor-induced T cell downregulation is mechanism of action of the checkpoint inhibitors, so E, ipilimumab. The last group of questions here is looking at key toxicities to the antineoplastic agent. And we're looking at congestive heart failure, hypertension, colitis, pneumonitis, and hypophysitis, atrial fibrillation, and hematuria. These are things that you could certainly encounter in the hospital or in your outpatient practice. Okay, and the answers are for 24, congestive heart failure. Trastuzumab is the answer. All of the HER2-directed antibody therapies are associated with potential decrease in EF, and routine echocardiogram monitoring is recommended to evaluate for this. 25, hypertension. This is a common side effect of bevacizumab and all of the VEGF inhibitors. For 26, colitis, pneumonitis, and hypophysitis are very common side effects of checkpoint inhibition. The first two can be life-threatening, and the last there is one of the few permanent side effects if this occurs. They will need lifelong hormone supplementation. So the answer to this is pembrolizumab E. 27, atrial fibrillation. This is a side effect of ibrutinib, which certainly can be picked up in general practice. And some of the newer BTK inhibitors, the class of ibrutinib, are less associated with this effect of atrial fibrillation. And finally, hematuria is associated with cyclophosphamide, particularly high doses. So if you have any questions, we'll discuss them on the chat function, and I'm also happy to take any email questions later. Thanks very much for your time.